So it's been quite a while. I really wanted to do an updated talk on DKA and HHS because there's a lot that we need to talk about concerning this particular topic. So this is a lecture that is going to help you understand the continuum of the hyperglycemic crisis and understand the pathophysiology, the diagnosis, and the management of the conditions. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at DKA and HHS, pretty much looking at hyperglycemic crisis. Remember that this is a continuum. Way back we used to think that DKA actually is a condition separate on its own and HHS is actually another condition that is separate on its own. But we have actually gotten to realize that these conditions actually exist on a spectrum. There are some patients that may present to you with, of course, DKA, but they are type 2 patients, or they can present to you with HHS, but they are type 1 patients, for example. So it's not just specific that patients with type 1 will present with DKA and patients with type 2 diabetes will present with HHS, because there's even some overlap in terms of presentation of type 1 and type 2 diabetes. So like I already told you, it was way back we believed that DKA was exclusive to type 1 diabetes, where they have insulin deficiency, and HHS was exclusive to type 2 diabetes, where they have insulin resistance and they have a bit of some insulin that is present. But reports are saying that both DKA and HHS can happen in either type 1 or type 2 diabetic patients. So keep that in mind. So by the end of this lecture, we should be able to define what DKA and HHS is and how they relate to each other on the hyperglycemic spectrum. We should be able to explain the pathophysiology of the conditions, what mechanisms are shared, and what are the differences that we can outline. We should be able to outline the diagnostic criteria and the clinical features that we expect. Of course, this will be talked about when we look at the pathophysiology, and we should be able to discuss the management of DKA and HHS patients, currently what we're doing for our patients. I will highlight a little bit about transition of the patients, but that will be a video on its own on how to transition patients from a DKA regimen to a basal bolus regimen, for example, or an HHS regimen to a basal bolus regimen. So this is, of course, going to be linking with evidence-based medicine, so there will be a lot of journals that I'll link to that you can actually have a look at. I've taken some screen grabs of them that you can actually read through. So remember that these hyperglycemic crises are going to be arising because there's this uncontrolled diabetes mellitus. And these hyperglycemic crises are acute complications, and they're going to be resulting in significant morbidity and mortality. I want you to remember 3 of them. There's hypoglycemia, which I won't talk about in this lecture. There's diabetic ketoacidosis, and there's hyperglycemic, hyposmolar hyperglycemic state, what was previously referred to as the hyperglycemic non-ketotic osmolar state, or also non-ketotic hyperglycemic coma, but no one calls that anymore. So we refer to it as HHS. Now, remember that DKA often is going to be due to someone having a stressor that is present. We'll talk about the different stresses. And this person will have an absolute insulin deficiency. They have no insulin whatsoever. Because remember that this insulin is what's going to be inhibiting the process of ketogenesis. Then on the other end of the spectrum, in patients with HHS, the hyposmolar hyperglycemic state, these patients now have a stressor as well. Just like with diabetic ketoacidosis, they also have a stressor, but the difference here is that they have some insulin that is present. So this insulin will inhibit ketogenesis to a large extent. So one of the major fundamental differences that we see is that patients with DKA will have some ketonemia, while those with HHS may have mild or no ketosis at all because of the insulin that is inhibiting ketogenesis. I got a picture of a screen grab just to have a deep dive into the biochemistry that is related to this. Then remember also that both patients are going to have hyperglycemia, but the rise in blood glucose will be much, much higher with HHS than we see with DKA. Remember that most of your RBS machines that you have in the ward generally can go at a maximum of about 32 millimoles per liter. So beyond that, it will just record high. But if you send that blood to the lab in a gray top bottle, then you may actually see that in hyper or smaller hyperglycemic state, it's much more severe than compared with DKA. Then, of course, in DKA, there's these acids that you're producing, these keto acids that are increasing the anion gap. So they have a large anion gap metabolic acidosis. While as those that have hyperglycemic state, hyposmolar state, have significant dehydration. Some of the triggers that we see, these triggers, remember, are common to both DKA and HHS. The two most common ones is patients coming in with non-compliance to medication. If they have been found with a diagnosis of a diagnosis of diabetes, type 1 or type 2, and they're not compliant to the medication, they'll come in with these acute stressor or these hyperglycemic crises. Then it could be due to infection. In 40% of the cases, we see that it could be due to a pneumonia or UTI. It could be due to pancreatitis, an acute flare-up. Cardiovascular conditions like acute myocardial infarctions. You have strokes, stresses, which could be due to surgery, trauma, or burns. Sometimes it could even be psychological or emotional trauma. And there is a group of drugs that we used, and I talked about these drugs when we talked about heart failure, the SGLT2 inhibitors. Remember that there are different trials that were done. For example, the Emperor's trial that was done to actually look at the efficacy of the SGLT2 inhibitors in patients that actually have heart failure with preserved ejection fraction. There are other different trials that were done with dapagliflozin, and they were shown to actually improve heart failure mortality, even if the patient doesn't have diabetes, but more so if the patient has diabetes, because they do work also to control the blood sugars. Remember how these drugs work. They're going to be blocking the reabsorption of sodium. They're going to be blocking the reabsorption of glucose. So ultimately, these patients are going to present with a type of diabetic ketoacidosis that we refer to as euglycemic DKA, where they will have the ketones, but because now they are releasing a lot of this glucose inside their urine, and they are losing this glucose inside their urine, then their blood glucose may actually be normal, but they still have ketones. We call this as euglycemic DKA. There are some drugs that you need to be wary of that may trigger diabetic ketoacidosis as well as HHS, corticosteroids, thiazide, sympathomimetic agents, pentamidine are examples of drugs that you should think about. Now, in terms of epidemiology, remember that diabetes contributes to about 11.3% of the deaths globally, and about 4.2 million deaths are between the ages of 20 to 79. Half of these are going to be due to people that are under the age of 60, or about 46.2%. And in Africa, we have seen that DKA and HHS, the prevalence actually varies. And we see that there are higher rates of patients with type 1 diabetes and DKA than those with type 2 complications. But remember that your patients that actually present with type 2, or rather HHS, actually have a higher mortality rate, because most of these will have inherently a poorer overall health status. They have significant other comorbidities that are there. So generally, the mortality rates are much higher with HHS than they are with DKA. So DKA is accounting for about 26 to about 41.3% in sub-Saharan Africa, and significantly higher than in developed countries. And then HHS is about 20.3 in Jamaica, though this is not in Africa, but Jamaica is considered in the context of a low to medium income country. Now, keep in mind that your patients that are having type 1 diabetes, the underlying problem that is there is that these patients are the pancreas is being destroyed. They're not producing enough insulin. They're not producing insulin at all. So the beta cells are being destroyed. So it means insulin is not there to inhibit the process of ketogenesis. So the patients that on the other end of the spectrum that have type 2 diabetes, they do generate some sort of insulin, and this actually is what inhibits ketogenesis. However, this insulin is not enough for you to bring down the blood glucose level. That's how these people have the hyper-osmolar hyperglycemic state. Then patients may actually present with different signs of both conditions. For example, a patient that is having DKA may have enough insulin actually to inhibit ketoacidosis to some extent, but their level of hyperglycemia may still be high. So there may be an overlap between DKA and HHS. It may be a bit confusing for you as a physician. Then depending on the ability to manufacture insulin and the extent of the other comorbidities, like for example, dehydration, patients with HHS may also have some sort of acidosis. They may have some sort of ketosis that may be there. Now, I want you to keep your mind open. This looks so complicated, but it's actually very easy to understand. So we'll begin to discuss about DKA. So someone will have an acute stressor, those stressors that we talked about. And then in the background, remember when they have these stresses, what gets released? These counter-regulatory hormones, which are the cortisol, the glucagon, and once this cortisol and glucagon are released and together with those catecholamines, remember that these are going to be stimulating processes that will increase the synthesis of glucose. So they're going to stimulate the breakdown of proteins because they're catabolic hormones. So they'll break down proteins into amino acids. Some of these amino acids are substrates to enter into the gluconeogenic pathway. Remember that gluconeogenesis is a process of synthesis of glucose from non-carbohydrate precursors. So you're going to have increase in protein breakdown, which is known as proteolysis, decrease in protein synthesis. So this is going to increase the gluconeogenesis. So this is in essence, this increase in gluconeogenesis is contributing to hyperglycemia. We see this in both DKA, we see it also in both HHS. In addition to this, remember that these counter-regulatory hormones are also going to stimulate processes that are going to inhibit the storage of glucose. So it means that glycogen is going to be broken down to your glucose. So now once the glycogen has been broken down to your glucose, you refer to this as glycogenolysis. And remember that this is also contributing to a high blood glucose level. So this is common to both HHS and it's also seen in DKA. Now remember that in patients that have DKA, they don't have insulin. And remember that there are some cells that need to be working as alternative sources. They need an alternative source of energy, cells of the eyes, cells of the retina, cells of the brain. So the body has to counteract this. And how does the body counteract this? These counter-regulatory hormones also stimulate the breakdown of lipids. They stimulate the the lipoprotein lipase enzymes that are going to be participating in lipolysis. And this is going to be the breakdown of those triglycerides into the free fatty acids plus the glycerol. And these free fatty acids are going to be, some of them can be channeled into the gluconeogenic pathway where you synthesize even more glucose. Some of them are going to be channeled into the synthesis of ketones, your beta-hydroxybutyric acid, your acetoacetate, your acetone. And these are going to be, some of them are excreted in the breath, like your acetone, giving this fruity breath that we see in DKA patients. So it means that your alkali reserves are going to reduce and these keto acids accumulate inside the bloodstream. And once these keto acids accumulate inside the bloodstream, the pH of the blood has been dropped. These are sensed by certain sensors in the respiratory system, kickstarting your respiratory rate and increasing your respiratory rate. They have this air hunger, this characteristic breathing, which is known as Kussmaul's respirations. And this is key in DKA because they don't have any insulin to stop the process of ketogenesis. We don't see that in HHS because in HHS they have some relative insulin deficiency and this is actually inhibiting ketogenesis, so just there'll be minimal ketogenesis. Now remember, all these processes are actually working together to actually increase the glucose that's going to be present in the bloodstream. And remember that glucose is hygroscopic, meaning it draws water towards itself. So this is going to mean that this glucose is going to be filtered out by the kidneys and it's going to exceed the transport maximum of the kidneys, such that once you have this excess glucose in the kidneys, it will draw water into the kidneys. So there'll be loss of water, there'll be loss of these electrolytes leading to dehydration. And this is actually coupled with decreased fluid intake in patients with HHS. There's this hyposmolarity, very common in HHS, and this dehydration results in impairment of renal function, further perpetuating the hyperglycemia, further worsening the cycle, and that's how patients actually present. Now I'll take a step back to actually look at the process of ketogenesis. This looks very complicated, but it's actually very easy. So we have our type 1 diabetic patients that have this severe insulin deficiency, and it could be a stressor that may be present, an intercurrent illness that may be present, and you have these counter-regulatory hormones that are produced, the catecholamines, as well as the cortisol and the glucagon. These stimulate your hormone-sensitive lipase, And once this is stimulated, your triglycerides are broken down to non-esterified fatty acids and glycerol. And these non-esterified, this is happening in the adipose tissue. These non-esterified fatty acids are then taken to the liver, and inside the liver, these are going to be combining with coenzyme A to form the fatty acid CoA, and they're going to be shunted through the carnitine shunt, and these are entering now into the mitochondria. Remember that the fatty acyl CoA will undergo beta oxidation through various steps. Acetoacetate will be formed. Acetone can be produced by decarboxylation, and 3-hydroxybutyrate can be produced in the presence of the 3-hydroxybutyrate dehydrogenase. This is what's happening in the process of ketogenesis. Now, remember that these processes are happening in the adipose tissue. This is the same diagram here. So in the adipose tissue, as you can see, the triglycerides here are being broken down to glycerol and free fatty acids. The glycerol is taken up. It can be taken back to the liver. It could be recycled. The free fatty acids, the non-esterified free fatty acids, are also taken to the liver. Similar thing is happening in the muscle, but remember in the muscle, your proteins are being broken down to amino acids. Alanine can actually be taken up by the liver and can be used to synthesize pyruvate, which can enter into the cycle, the provision of energy. Then your muscles are also going to be converting some of the protein into lactate, and some of this lactate can also be converted into pyruvate. Some of this lactic acids accumulates even in the bloodstream, and epinephrine will still synthesize the glucose from the glycogen, and glucose can also be used to synthesize other precursor molecules. This is what's happening in the muscle. This is what's happening in the adipose tissue. Now, coming to the liver, we have the free fatty acids that are entering this carnitine shunt, and the free fatty acids are combined with coenzyme A, and then it enters into the mitochondria. In the mitochondria, beta oxidation happens, acetyl-CoA is formed. Acetyl-CoA can enter into the Krebs cycle to produce carbon dioxide and water together with energy. Then your acetoacetate is going to be formed. Acetoacetate can be then further converted to mevalonate or mevalonic acid, which could be used to synthesize cholesterol. Then it can also be further decarboxylated to form your acetone eventually, and your beta hydroxybutyrate. These are the things that are going to be accumulating. Your beta hydroxybutyrate, your acetone are going to be accumulating in your bloodstream, and these are keto acids. They're going to be dropping the pH of the blood. Then, of course, some of these oxaloacetate and the acetyl-CoA, which are formed from the pyruvate, can actually be taken through several steps into the phosphol, can be converted into oxaloacetate, can be pumped out into the cytoplasm, into the phosphoenol pyruvate, and then eventually this could be used to actually synthesize glucose, which is contributing to the gluconeogenesis, because remember that this is coming from the proteins that were broken down and is coming from the lactate. So these are some alternative sources to which glucose actually is contributed to be synthesized inside during these processes of ketogenesis. Just to remind you again, your beta oxidation, which is happening inside the mitochondria, your acetyl-CoA, and then there's going to be a thiolase, there's going to be an HMG-CoA synthase enzyme, an HMG-CoA lyase enzyme, and then they're going to form your acetoacetate, which could either be decarboxylated to acetone, or it could be in the presence of a dehydrogenase enzyme, be converted to beta-hydroxybutyric acid. So we actually check for these ketones in the bloodstream, but it's something that is very important that we'll mention. Some of the acetyl-CoA can enter into the Krebs cycle to actually synthesize energy. Some of it can be converted to oxaloacetate, which enters in and is going to be converted to the phosphoenol pyruvate, which could be converted to glucose in the process of gluconeogenesis. These are very important reactions to actually remember. So it means that there's an overlap between the presentation of HHS and the presentation of DKA. So HHS tends to have rather a gradual and an insidious type of onset. So generally we see it over days to weeks, while as DKA actually happens over hours to days. So if you get a rather rapid type of presentation, be thinking more or less DKA more than HHS, but if it's a gradual thing, think HHS. HHS will have prominent neurological symptoms, so usually they tend to be confused. they tend to have decreased levels of consciousness. Whereas DKA tends to have prominent GI symptoms. They tend to have this abdominal pains. We don't see abdominal pains in HHS, but we see them for some reason in DKA patients. Then there is no acidosis or mild acidosis, but there is metabolic acidosis in DKA. And remember, we can use the pH of the blood to classify the severity. For those that have a pH that's less than 7.3, or rather 7.2 to 7.3, that's mild. Then 7.2, or rather 7.1 to 7.2, that's moderate. And less than 7.1, we consider that as severe. Then you have significant ketones being formed with DKA. We don't have any ketones in HHS, but we have hyperglycemia and dehydration in both. The hyperglycemia is much higher with HHS than with DKA, and the dehydration is more with HHS than it is with DKA. So what are some of the clinical features? Remember, compared to HHS, DKA develops more quickly, and you have the classic symptoms of hyperglycemia, the polyuria, the polydipsia, the weakness, the altered mental state. They're present in both of these conditions. And of course, your patients with DKA have this fruity breath that I already talked about, and they may exhibit dehydration-related symptoms like dry mucous membranes, your poor skin turgor, your tachycardia, your hypertension, your increased capillary refill time with severe dehydration. The unconsciousness may result in DKA, and if it continues to worsen, and if it's not treated, it may actually result in death. So DKA, generally, they may have abdominal pains that may mimic an acute abdomen. They may have nausea and vomiting, fruity breath because of the acetone. They may have this deep, fast breathing, which we call the Kussmaul's breathing or the Kussmaul's respirations, or this air hunger. Here are some of the differences. Like I said, we can use the pH. So about your 7.25 to about 7.30, that's mild. Then about 7.2 to about from 7 to 7.2, anything less than 7 is considered as severe. I think I should have said 7.1 earlier on, but it should be less than 7. Then your pH in HHS is greater than 7.3. Then here the sugars in DKA, whether it's mild, moderate, or severe, are all actually greater than 250. If you want to change this to millimoles per liter, you divide by 18. So you divide this value by 18. So if we actually divide your 250 divided by 18, it gives us roughly about 13.9. So your sugars should be above 13.9. But remember, in patients with euglycemic DKA, your sugars may be normal. Then for those that have HHS, it's actually even as high as 600 milligrams per deciliter. That's about 33.3 millimoles per liter. When you look at the sodium bicarbonate, in mild, DKA it's 15 to 18, moderate is 10 to 15, severe is less than 10. Ketones are positive in DKA, they are small or trace in HHS. Serum ketones are positive in DKA, we don't really see them in HHS. The osmolarity can vary in DKA depending on dehydration, but it's quite high in HHS because your patients are severely dehydrated. An ion gap is elevated in DKA, so greater than 10 in mild, greater than 12 in moderate and severe, while this is variable in patients with HHS. Mental state, they are usually alert in mild DKA, alert or drowsy in moderate DKA, stuporous or comatose in severe DKA, and are usually stuporous or comatose in HHS. I'll talk about how you calculate the osmolarity very shortly. So some useful tests that you'd want to order: a full blood count and a differential count, your arterial blood gases, do your renal function test, your urea creatinine, and your ABGs, do your electrolytes, your sodium, your potassium, your chloride, your ionized calcium, your phosphorus, and your magnesium. In terms of the diagnosis, how do we make a diagnosis? Remember DKA, so you should have some diabetes or hyperglycemia greater than 11.1, or they should have a prior history of diabetes. Second thing, they should have ketones. The ketones in the blood are more important, especially with beta-hydroxybutyric acid. So greater than 3 millimoles per liter, or if you have a urine dipstick, one that's greater than 2 plus or more. Then your acidosis, that should be present, a pH less than 7.3 or a bicarb less than 18. You have these three things, you have a diagnosis of DKA. In terms of HHS, remember there's hyperglycemia, but it's quite high, greater than 33.3. You have hyperosmolarity, so you calculate your serum osmolality greater than 300 milliosmoles per kg. How do we calculate it? We say 2 multiplied by the concentration of sodium in millimoles per liter plus the concentration of glucose in millimoles per liter. So let me give you an example. Suppose your concentration of sodium is roughly, your corrected concentration of sodium is roughly about 146. So we're going to say 2 multiplied by 146, that gives us 292. And let's say that your blood glucose is about 35. You add 35 to that. So the answer is going to be 327 milliosmoles per kg, which is actually increased. So your serum osmolarity in this case would be increased. Then if you want to calculate the total serum osmolality, you're going to say your 2 multiplied by your sodium concentration. Again, you add the concentration of glucose in millimoles per liter. Then you also add the concentration of urea in millimoles per liter. This one should be greater than 320 for you to say it's elevated. Then they don't have any significant ketones, so you don't have any urines in the ketones, less than 2 plus, and in the blood is less than 3 millimoles per liter. The pH is greater than 7.3, their bicarb is greater than 15 millimoles per liter. Now, what are some of the pitfalls? And these are very important for you to keep in mind. Remember that most of your lab tests are actually going to be using what is known as the nitroprusside method to detect the ketones. So they're going to be detecting acetoacetate. Remember, acetone is breathed out, then acetoacetate is what you're going to be detecting in the urine. The urinalysis does not detect the beta-hydroxybutyric acid. And remember that beta-hydroxybutyric acid can be converted to acetoacetate, especially when you start treating your patients. So you may get a situation where your patient is actually improving, and then you do your urine dipstick. It was initially 3 plus, then the next morning it's 4 plus, but your patient clinically is getting better. You shouldn't worry because the dipsticks don't check for beta-hydroxybutyric acid, so some of it could actually be converted to acetoacetate. There are also some drugs that may give you a false positive, especially drugs that have a sulfur hydro group that may actually interact with the reagent in the nitroprusside reaction. So an ACE inhibitor, specifically captopril, not all ACE inhibitors, but specifically captopril, penicillamines, N-acetylcysteine, and even bosilamine can actually interact and give you a false positive. Then generally, follow-up should be done with the blood ketones. So you should measure blood ketones. That's what you should use for follow-up to judge if your patients are improving. But there are now some newer glucometers that can actually measure the beta-hydroxybutyric acid inside patients with DKA, so to overcome this problem. Again, you may have falsely elevated lipase, especially if you're suspecting this is a pancreatitis. Remember, the plasma glycerol levels are quite high because of the rapid breakdown of the adipose tissue, the adipose triglycerides. So you may think that someone has an acute pancreatitis, so you may think that the lipase is elevated. So remember, glycerol is a product that is measured in most of the assays that we use to check for the plasma lipase enzyme. Serum creatinine may be artificially elevated because of the interference of the ketone bodies, especially when you're measuring your creatinine using your calorimetric method. Then you notice that the creatinine is going to be actually elevated. Here's a much massive table to actually distinguish many different things that are there. I won't spend some time looking at this, so I'll just leave it on your screen. You may get a screen grab. I think it's self-explanatory. Comparing starvation, DKA, lactic acidosis, uremic acidosis, alcoholic ketosis, salicylate intoxication, methanol, hyposmolar coma, hypoglycemic coma, rhabdomyolysis, and isopropyl alcohol. So you may pause the video, take a screenshot. I think this is a very self-explanatory thing. Now, we'll come to the last bit, which is management. What are the goals of a therapy? So we want to improve the circulatory volume and the tissue perfusion. We want to gradually reduce the serum glucose and osmolality. We want to correct the electrolyte imbalance. We want to identify and promptly treat any comorbidities that may be precipitating causes that may be causing these patients to be DKA or HHS. So generally, these patients need to be monitored frequently. So you don't want to put them in a place where they are not going to be monitored so frequently because you find that they have deteriorated. So your patients with HHS, like I said earlier on, will have a higher mortality rate because they have this underlying poor health. They have this significant dehydration. So these actually should be closely monitored. So there is a mnemonic that you should remember, which is known as FIPA. So F for fluids, I for insulin, P for potassium, and A is for and others. So it could be antibiotics, it could be electrolytes. Remember that your patients with DKA largely will require about 10 to 18 hours for you to control the sugars, and with HHS it's about 9 to 11 hours. So if you come after 18 hours, your patient isn't improving, it means there's something that you're not doing. Then we'll start with the fluids. So remember that generally patients have a deficit, significant deficits. In DKA, they lose about 100 mils per kg. So if you're assuming that someone, an average is about 70 kilogram man is in DKA, they would have lost about 7 liters of fluid. And then in terms of sodium deficits, about 7 to 10 millimoles per kg. Chloride is about 3 to 5 millimoles per kg. Potassium is about 3 to 5 millimoles per kg. HHS is much more greater deficit, so about 100 to 220 mils per kg, so about 9 to 10 liters total body water deficit. Sodium deficit about 5 to 13, about 5 to 15, about 4 to 6 in terms of potassium. Now, when you replace this fluid, the route of administration for this DKA and HHS is IV. Generally, in terms of the most of these literature, fluid of choice is actually normal saline. But there is some recent evidence that has actually suggested that patients would actually benefit from balanced crystalloids, especially those with DKA. Why? Because it has a lactate buffer that could actually buffer the acidosis, and more so, giving large amounts of normal saline could actually result in vasoconstriction of the renal arteries, can lead to renal vascular events. So there are different studies that were done that showed actually that the balanced crystalloids could be potentially used to actually treat patients with DKA. But according to our guidelines, our standard of choice remains as normal saline. So when they come in, you check their BP. If their BP is low, you bolus. You give them 1 liter of fluid over 30 minutes. You recheck their BP. If it's still less than 90 over 60, you can rebolus them. Consider whether this patient is in septic shock and they may need inotropic support. If the patients do improve, continue them on 1 liter over 2 hours, 1 liter over 4 hours, then you reassess the rehydration status. You want to, after about 4 hours, you want to target the urine output about 0.5 mils per kg per hour, and you should be matching the urine output of this particular patient as you go. And remember that the fluid of choice also depends on the blood sugars. Once your blood sugars are now less than 13.9, you're going to be switching them to something that has dextrose in it so that they do not actually tip into hypoglycemia. There is some special groups that you should look out for features of fluid overload, and you must use the fluids with cautions. Patients that are elderly, patients with that are pregnant, patients with heart failure, patients with kidney failure, those with hypertension, those with an age of about 18 to about 25, this risk of cerebral edema. So in terms of the fluids that you can give, instead of giving them, let's say a 1 liter bolus, you could give them a 500 mils or a 250 mils and then see their response and not really overload these patients with fluids. And then in terms of HHS, remember that the estimated fluid loss is about 12 liters. 50% of this deficit, you should aim to replace it in the first 12 hours. The remaining deficit, you should aim to replace it in about the next 12 hours. So you can give 1 to about 1.5 liters in the first hour, 1 liter in the second hour, 1 liter over 4 hours until the hydration status actually improves. So you want to generally monitor the hydration status, make sure your urine output again is greater than 0.5 mils per kg per hour. Then of course, after about 4 hours, you should have gotten your electrolytes, you should have gotten reassess your patient, look at the clinical condition, look at the hydration status to see if you can add something or you can change something. Then in terms of insulin, remember that you're going to be giving your short-acting soluble insulin. This should only be given if your potassium is greater than 3.5. If you actually read some other guidelines, they use a lower threshold of 3.3, and you make sure that your patient is hydrated. Because if you give insulin, insulin is going to drive potassium into the cells. So remember that insulin will drive glucose into the cells because of expression of those glucose transporters which are dependent on the insulin. Then that glucose will be metabolized by the cells, and once it's metabolized by the cells, it's going to result in the production of ATP. ATP runs the sodium-potassium ATPase pump, which pumps out 3 sodium ions in exchange for 2 potassium ions, and this will drop the serum concentration of potassium, which may exacerbate certain arrhythmias and you may kill your patient. So you make sure that your potassium concentration is above 3.5. And supplements, remember you should aim for a potassium concentration between 4 to 5. So generally your regular insulin can be given as a continuous infusion. We start off at a dose of 0.1 units per kg per hour. So roughly to come up to a dose of 6 to 8. Maximum 10 international units. Don't give above 10. So for actually my younger candidates on the ward, I usually tell them, if the person is quite skinny, small, use 6 international units. If they're on the larger side of life, use 8 international units. Then you're going to give this hourly as an infusion. So how you make this infusion, you get 50 international units of soluble insulin. You add it to about 49.5 mils of normal saline to make 50 mils. So you're going to create a concentration of 1 international unit per mil. Then you're going to use an infusion pump and you run it at 6 mils per hour. And then once your RBS drops to less than or equal to 13.9, you run it at half the rate. So if it was at 6, you run it at 3. If it was at 8, you run it at 4. So you're targeting a drop in glucose about 3 to 4 millimoles. This should be per hour, 3 to 4 millimoles per hour. And generally, you want to keep your RBS between 8 to 10 until your ketoacidosis resolves. It shouldn't drop below this. It shouldn't rise above this. So to make sure that your patient is not actually hypoglycemic, if the blood glucose drops to less than 4, you stop the insulin, you give them some dextrose, 50%, 40 to 50 mils. Then you check their, after 25 minutes, you check their glucose until it's greater than 6 millimoles per liter. There are some regimens where you could use intramuscular. However, this method is quite painful. We should avoid it and generally puts the risk of patients bleeding, especially if they're taking anticoagulant therapy. In terms of potassium, remember that potassium could either be normal, it could be low, or sometimes it could be high. So remember that the reason why it's low is because these patients may be vomiting, they're losing potassium. Moreover, they have this acidosis and they have this renin-angiotensin system that is stimulated because of the dehydration that is there. Remember, you're retaining sodium at the expense of potassium. So this is what's contributing to the hypokalemia. So generally, if they have metabolic acidosis, especially in DKA or even those that have type 1 tubular acidosis, you correct the hypokalemia before you actually even give any bicarbonate, before you actually give any insulin. If you have tried to correct the hypokalemia and it's not being corrected, then you should think maybe the problem with magnesium. Order some magnesium assays and actually give them some magnesium sulfate. So they may have a magnesium deficiency. So make sure you address that. Otherwise, you won't correct your potassium. If your potassium is less than 3.5, don't give insulin. So your target is about 4.5 millimoles per liter. And how do we calculate the deficit? One estimated ratio that we could use or equation is the lower limit of your potassium. So in this case, it's about, you are going to use our 3.5 minus the measured potassium. So if this patient is, let's say, has a potassium of 2.5, so 3.5 minus 2.5 is 1. If they're weighing 40 kg, you multiply that by 40, so it's going to be 40. Then 40 multiplied by 0.4 is going to be about 16. So their deficit is about 16 millimoles per liter. But remember that for every drop that you have in potassium, you can just say for every drop of any drop of 0.1 millimoles, it means that the total deficit in the body is about 35 millimoles. So for that same particular patient, if it has dropped from 3.5 to about 2.5, so it means that they have dropped by 1. So it means that 1 divided by 0.1, 1 divided by your 0.1, that's about 10. So you multiply that by 35. So in essence, this person will have a deficit of about 350 milliequivalents of potassium chloride. So it means that if you were to actually replace it with, every time you're replacing with 40 milliequivalents, it means you have to give about 8 infusions total for you to get them to about 3.5 millimoles per liter. I don't know if that makes sense, but I hope it makes sense. If it doesn't, play over it again. It will definitely make sense. So your infusion rate of potassium chloride must never exceed 10 milliequivalents per liter on a peripheral line. So often we usually say 40 milliequivalents, we add it to 250 mils of saline and we let it run over 3 to 4 hours. Basically, it's safer to run over 4 hours so that you don't exceed 10 milliequivalents per hour. If you have a central line, you can even much better, because remember, potassium chloride is quite irritant to the vessels. Then you assess the potassium every 1 to 2 hours, and then of course if there's no access to ABGs, don't exceed 10 to 20 milliequivalents of potassium chloride per dose. So generally, if the sodium concentration, or rather the potassium concentration is normal, 3.5 to 4.5, we give 20 milliequivalents of potassium chloride in alternate liters. If it's less than the 3.5, meaning they're hypokalemic, we give 40 milliequivalents. If it's above 5.5, we don't give potassium chloride. But how many times will you give it? This last point here will actually be very important for you to remember. Bicarbonate is not routinely given, so generally we don't administer bicarbonate, and it has not been shown to improve outcome of our patients. It doesn't have any effect on the length of hospital stay, the resolution of the acidosis, or even mortality rates. But for our patients who have a pH that is persistently less than 6.9, despite your adequate fluid resuscitation, we can consider bicarbonate solution, about 50 to 100 millimoles of it, in about 400 ml of water, and you can give it until the pH is greater than 6.9. There is a risk of decreased cardiac contractility and arrhythmias, which is why we tend to avoid it and only give it for our patients that are in the ICU or in resus. Then the bicarbonate is not advised for those that have mild DKA, and if the pH is above 7, or if they have HHS, we don't want to give our bicarbonate. Other measures that we can do, if your patient has the altered mental state, or they are persistently vomiting, protect their airway, push in an NGT. There's a risk of aspiration. If they are immobilized for some time, consider thromboprophylaxis with low molecular weight heparin, unless if there are contraindications, they should have continuous ECG monitoring in these patients. Then in terms of monitoring for other things, your blood glucose should be done hourly for the first 8 hours, so aim for a 4, about 3 to 6. Even 6 is quite high, so about 3 to 4. Your urea and electrolytes, do your baseline, then monitor them hourly until 6 hours, then a 12-hour leave, and then at 24 hours. Your creatinine, do it at 0, 6, 12, and 24 hours. Your ABGs at 0, 2, and 6 hours after. Your bicarbonate at 0, 1, 2, 3rd hour, 6th hour, 12th hour, and 24 hours. So you can see that the monitoring of these labs is quite intensive, and it must be done strictly, especially these patients that are ending up in the ICU. So there are some markers that would tell you that this person has resolved. They're out of the DKA, they're out of the HHS. You can use biochemical markers, you can also use clinical markers. So your level of consciousness will improve, they'll be alert and oriented. They will be able to feed orally. If there's no contraindication to feeding orally, there won't be any signs of dehydration. That's how you know that your patient has improved. Biochemically, your ketones are going to be reducing in the bloodstream. The pH is going to normalize greater than 7.3. They'll have a normal anion gap. Your bicarbonate will normalize at 18 milliequivalents per liter. Your glucose is less than 13.9. That's how you know that this has resolved, and you can actually transition them from your DKA regimen to your usual basal bolus regimen. I'll do that in another video. So just a glance about the transition. Remember that after the DKA has resolved, your patient should be feeding orally, and you can switch them to the basal bolus. If they are still nauseated, if they are vomiting, then the IV infusion of insulin and the fluid therapy should continue. When you're starting your regular insulin, your bolus doses, remember that the insulin infusion should be stopped 30 to 60 minutes after the commencement of the subcutaneous insulin to prevent the rebound effect, to prevent the glucose from shooting up again. And then this overlap, like I said, will prevent the interruption. And as soon as the short-acting subcutaneous insulin takes its action after 30 minutes to set in, then you can stop the infusion. So to prevent that shooting up of the glucose, you have to wait for at least 30 minutes, then you stop the infusion that you're giving your patients. But I'll talk about this in a whole lot detail when you look at another video on transition of patients from DKA to a normal regimen of insulin, and also from HHS to a normal regimen of insulin. So generally some guidance, I think this should be the last slide, some guidance to help you. Remember that you want to look out for features of infection, treat those, put them on antibiotics. The features of CVA, myocardial infarction, sepsis, DVT, you want to address those. Pay close attention to the fluid correction and the electrolytes, especially in the first hour of treatment. Gradually correct your hyperglycemia and your acidosis. Don't do it too quickly. Then correct the fluid loss. It is going to obviously correct your acidosis. Then presence of mild dehydration, you should think that they have already lost at least 3 liters of fluid. Only discharge your patients or switch them back to your daily insulin regimen when they have resolved, when they have met those clinical and biochemical criteria. So when the condition is stable, your pH is normal, your bicarbonate is normal, the patient is able to eat orally, you can switch them to the subcutaneous doses of insulin. If they're still nauseated, if they still can't eat, continue your dextrose infusion with your hourly insulin infusion. Complications include hypotension, coma, cerebral edema, hypothermia, hypophosphatemia, pneumonia, aspiration pneumonitis, DVTs, or complications of the therapy itself that may lead to hypoglycemia, hypokalemia, hyperkalemia, pulmonary edema, and hyperchloremic acidosis, especially with infusion with large volumes of normal saline. I really hope you enjoyed this video on an updated talk on HHS and DKA. If you haven't watched the videos on DKA, I will leave them tagged in the description below, and I'll leave them tagged in the comment below. Until next time, my name is Dr. Moses Kazevu. Bye-bye.